Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So today I'm going on a different path today because it still has to do with coding, but I'm finding more undercoding than overcoding. And, I'm here to tell you undercoding is no better than overcoding when found in an audit, when looking at compliance and what kind of invited risk is out there. And, I see these questions a lot. It says, people say I'm in need of written documentation to verify that undercoding is a compliance risk, much like overcoding. Where can I find this? Well, let me kind of break it down for you, especially what Medicare has to say about this. So the Centers for Medicare and Medicaid Services, and also through its Medicare Learning Network, the MLN, fact sheets they put out, it talks about Medicare fraud and abuse and prevention, detection, and reporting. And it doesn't specifically say downcoding or undercoding, but if you actually read the document over and over, you can recognize undercoding as a compliance risk. And what I mean by that is providers who feel that they can get paid quicker by coding a level 3, or they can save the patient some money under their copay by coding, a lower level 2 or 3 instead of a risk of, moderate complexity level 4. The worst one I've seen is when we're dealing with teaching facilities or the primary care exception, where you don't have a supervising provider supervising the residents. And so even though the patient was either a moderate or high risk encounter that day, they say, well, go ahead and just put it in as a level 3 so we get something. And that's misrepresenting what you're actually doing. So here is CMS's definition of fraud, so Medicare, and you want to pay close attention to this. It says, in general, and I know we don't like the F word, fraud, but just listen. In general, fraud is defined as making false statements or representations of material facts to obtain some benefit or payment for which no entitlement would otherwise exist. These acts may be committed either for the person's own benefit or for the benefit of some other party. In other words, fraud includes the obtaining of something of value through misrepresentation or concealment of material facts. Think about that. That reads right into undercoding as well. Deliberate undercoding, in reality, making a false statement about services provided, and is ultimately a misrepresentation of the facts. That fact sheet gives an example of fraud as knowingly billing for services that either were not furnished, which would apply if services were purposefully, undercoded. Undercoding also fits within the definition of abuse by CMS because it says misusing claims on a claim form. Under the False Claims Act, a physician may be held liable for submitting claims to Medicare, I'm quoting again, for medical services he or she knows were not provided, meaning you're coding something less than actually what was done. Within this context, you could argue that undercoding represents, quote, deliberate ignorance or reckless disregard of the truth related to the claim. Also, remember, this can have a domino effect. You've got a provider that says, everything's going to be a level 3 or a 2, and then all of a sudden they have to refer them out to a specialist who now is seeing them for cancer or for possible surgery or for, infectious diseases or something high risk. And now they're at a moderate or high, and they're saying, well, why didn't the primary care or previous doctor referring physician believe that this was a high risk or moderate risk or, an elevated care patient? There's also the criminal health fraud statute, which makes it a crime to, and I'll quote, to obtain by means of fraudulent pretenses or false pretenses, representations or promises, any of the money or property owned by or under the custody or control of any healthcare benefit program. Again, undercoding services could be perceived as false and fraudulent representations for the services provided. And then you get into the anti-kickback statute, coding services at a lower than actual levels could also be interpreted as an inducement to the patient. I mentioned before, lowering their copay or their out-of-pocket if they're on a 70/30 or 80/20 plan, or they're in a high deductible plan. This also could potentially be another violation of federal law. So there are a variety of ways that undercoding might potentially be considered a violation of fraud and abuse rules, and undercoding isn't playing it safe. It's misrepresenting services. Coding should be based on documentation, underlying medical necessity, and anything less is problematic. Another important aspect, and this is a real big one, remember we've got Optum and all these third-party players that are trying to now be utilized by the payers to find things that may or may not exist. But think about what this undercoding does. It establishes false utilization patterns, which may in turn flag a physician as an outlier, making him or her a target for payer investigation and audits. So I just wanted to make this as clear as possible because I'm seeing a lot of undercoding, and this undercoding is really skewing claims data. So your provider's claims data is not accurate. It's basically like what we're seeing in a lot of cities right now, that we're seeing the National Guard being sent in, okay? And I know this is going to be a touchy subject for some, but you see some of these city leaders saying, "Oh, our crime is down," but is it really? Have you skewed the data because you're not reporting it, or because you've relaxed the rules on that? So, it's a very similar thing to me, and it's important to note that undercoding is just as detrimental as overcoding. It doesn't ensure coding compliance. It has potential legal and regulatory ramifications, not to mention the revenue that is missed out on by the provider. So I was doing a chart review recently, and I noticed a huge undercoding by this surgery group, which was weird because usually I'm seeing overcoding. Everything's level 5 because I'm a surgeon. No, it was level 2s and 3s, and I'm like, what? And it was clear the patient was coming in for clear, moderate or high risk, or there was some low risk, but it just wasn't on a bell curve. And we know what a bell looks like. It was like a lightning bolt of just on the bottom end of that. And I was noticing each quarter there was, about 28,000 to 180,000 left on the table on the sample size that we did. And, overcoding was there too. That was about 6,000. But when I saw the exorbitant amount of missed revenue, not just that, procedures performed that weren't reported. And a lot of times I found that, yes, it was incomplete documentation or missed services, but then after doing more research and assessment and talking to billers and coders and providers, I found that they just didn't want the patient charged for it, or they just wanted to make sure there wasn't an out-of-pocket, and they didn't want to send it in to the payer. And a lot of times in these scenarios, the patient needed to have elevated services. Some needed to go to the hospital or have surgery, or just things that wouldn't warrant a straightforward or low E&M, or a service that did not have things included. And so it is hard sometimes to identify it, but it's really important, and as much as we look for potential claim issues and compliance issues with overcoding and overutilization, that you in your practice also understand that undercoding is just as much of a problem, and missing codes that now you can capture. Look at undercoding from regularly scheduled visits. Try to pinpoint services that are being missed. Hire an outside auditor. And this isn't to get, business for me. I'm busy. I'm happy to look, but I'm just saying, find someone that you trust, whether it be me or somebody else, to take a look and figure out, are you capturing, do you have any missed revenue? Do you have a pattern of providers that may or may not be over or undercoding? But I don't want to see anyone get in trouble for the fraud, waste, and abuse and plus losing money. And so you want to capture all work that's performed. Now, some of it is due to oversight and just not knowing what you can capture, but a lot of it is just due to, failure to educate or, fear of audits. So a lot of providers undercode, feeling that the scrutiny from payers, is a way to avoid audits. It's not, because there's a lot of data capture and algorithms now. And if you are of a similar specialty as to someone who codes higher, it may be looked at. So try to really be mindful that this could happen in your practice, and make sure that you're not falling into a trap of this non-compliance that could be then elevated to a fraud, waste, and abuse situation. And I just wanted to bring this to your attention because I just think it's not talked about enough. And it's definitely become an issue that you need to deal with in addition to overcoding. All right, so I hope everyone is surviving this heat. We are having a little bit of a heat wave, or I should say a lot in California, but they said, we're on a cooling trend. It's going to be in the 90s this week instead of over 100. I guess I should be happy for small victories. So there it is. So everyone, just so you know, we will be back with some top 10 Tuesdays coming back in September. Hope everyone enjoyed a little break there with Labor Day weekend, and that you're as excited as I am that the NFL season is going to start here soon. I'm tired of baseball. I really am. I am so ready for football. So everyone, make it a great day. Make it a great rest of your week. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.